So there are two types of pessary, support pessary and the space filling pessary. So support pessary, these are all the ring pessary, ring with support, ring with knob, Schatz pessary, Gellhorn, Hodge pessary. These are the support pessary. How they act is, they basically have spring-like action. So they act by spring-like mechanism in the vagina, and they basically give support to the superior part of the vagina. So they give support to the superior part of vagina. So posterior vaginal wall prolapse will not be cured or will be effectively treated with the help of support pessary, ring pessaries. Okay, so ring pessaries are not used for the posterior vaginal wall prolapse. Okay, so these are the support pessaries. Now the space filling pessary, they basically have action is like by suction. They create the suction all over the vaginal wall. They create space. Space filling pessary, they create the space in the vagina. Instead of prolapse, they create a space, and they try to make the diameter more than that of genital hiatus, so that the prolapse part does not come outside. Okay, so this is the space filling. Now, what are the space filling commonly used? Is a Gellhorn, donut, and the cube pessaries. These are the more commonly used space filling pessaries. Now, ring pessaries, they are usually used in stage 1 and 2 prolapse. They can be used for higher grades, but usually effective in first and second stages of prolapse and in the stress urinary incontinence, ring with knob. Space filling for the more advanced type of prolapse, you use the space filling pessary. Here the Hodge pessary, specifically for the Hodge pessary, when there is a case of narrow vagina, short vagina, you can try the Hodge pessary. I said in my last lecture also, in contraindication of pessaries, narrow vagina usually don't insert a pessary because they are very painful. So here you can try a Hodge pessary, it will be good, you get good results. Now, finally, how you insert a pessary, the most common thing of a pessary, how you insert. You first of all inform the patient that you're going to insert, you take the verbal implied consent, and then make sure that bladder is empty. Try to make bowel also empty, okay, dorsal lithotomy position, and then size of the pessary. So these are the silicone ring pessaries. See the softness, okay. These are the silicone ring pessary. You don't have to use the rubber or latex pessary. We don't use nowadays. So these are the silicone, non-allergic. It does not absorb any fluid or any discharge. So they do not give any odor, bad odor to the vagina. Okay, so these are the silicone. You make the patient feel it, because this should be the consistency in the follow-up also. When you teach even the self-care for the patient how to remove the cell, she should know the natural normal feel of the pessary. Okay, so this is the silicone ring pessary, and size how you take it. You basically insert your, suppose this is a vagina, so you insert both the fingers, middle and the index finger. Middle finger should be posterior, the posterior fornix, and the index finger just behind the pubic symphysis in the anterior fornix. Okay, then you take it out of the vagina. Okay, so after taking out of the vagina, you see what's the size of the distance, and you measure it with the of the pessary. Just a minute. Okay, so you keep the pessary, so you have removed this, and you see with the pessary what is the size, how much it is, and then according to that you insert a pessary. But now practically it is not possible. When you take the finger out of the vagina, so there will be some distance. You have to, obviously this is the inside, and when you remove it, so how you going to the, so practically it's not. So remember, the size of pessary you have to determine by trial and error. Yes, these are the 3 inches pessary, so they can 2, 2.5, 4, 4 and 4.5 inches also. So it's by trial and error. What other practical method you can do for the size of pessary is, you insert your index finger in the posterior fornix, and suppose this is the pubic symphysis, and then you mark at this point what the level of, you insert your index finger in the posterior fornix as high as possible, and you mark your index finger touching to the pubic symphysis. So this gives you an approximate idea. For just for the bony part, you can subtract 0.5, and that will give you an approximate idea of the pessary. So pessary is basically a trial and error method, and it usually requires 2 to 3 attempts for a correct size of the pessary. Less chances give 1 attempt you get it right. Okay, so this is the pessary, how you insert the size of the pessary. Okay, then you insert it as high as possible, and basically what you try to do is, when you insert a pessary, you try to hinge it on the pubic symphysis. Basically the main pubic symphysis is going to give the support of the pessary. So you try to insert the pessary as high as possible in the posterior fornix, and anteriorly you try to hinge it, put the pessary behind the pubic symphysis, because that is going to give the support. I'm talking about the ring pessary. Okay, so this is how you insert a pessary. So once you insert the pessary, then what are you going to do is, once you have insert this pessary, so you put off your finger, this is the vaginal wall and this is the pessary. You freely try to move your finger around the pessary. Okay, you just insert the pessary, so you try to freely move your finger. So there is that is not necessarily tight. There are no pressure, or also sores will not develop. If it's very tight, so it will develop. So you ensure that it's not too tight. So you should be able to move your finger freely around the vagina, between pessary and the vagina. Okay, this you do it. Then you ask the patient to do cuff, do stand, do valsalva. Okay, and very make sure whenever you insert a pessary, patient should have voided. After you insert a pessary, ask the patient to void, and she should have comfortably voided. Otherwise, you without voiding trial, you send the patient insert a pessary, and at home might be the size is wrong, or it's too large, it's obstructive, and the patient will not able to void. So whenever you insert a pessary, you ask the patient after that to curve, to stand, to do also, to see whether it's moving, it's coming out or not, and to void. Whenever you insert a pessary, your patient will have no pain. She may have slight discomfort, but patient routinely, a pessary patient will not feel that she is having a pessary inserted. I repeat, whenever you insert a pessary, patient will have no pain. Okay, she will not feel the pessary routinely, that there is a pessary inserted in her. At the time of insertion, obviously there may be some discomfort, that is okay, but routinely she will not have. And the most important thing is, whenever you insert a pessary, don't lubricate the pessary. If you lubricate the pessary, it will not even stick, and even your hands get slippery, so you will not, there will not be proper fitting. So whenever you insert a pessary, make sure that vagina is well lubricated. You give her some lubrication to the vagina, and some amount of, you can add the lignocaine jelly also. Okay, but you don't lubricate the pessary. Okay, so this is the how you fit a pessary, and after fitting, what instructions you give to the patient. Then these are the successful fitting pessary, and there are high chances, 85% there are chances that patient gets successful fitting of the pessary is achieved. 85% of cases. Unsuccessful fitting. The very unsuccessful fitting is size. If the size is not present, the patient pessary may fall out. Okay, or it may be obstructed. Patient may not void after you have inserted the pessary. That is unsuccessful. Then TVL. There are various studies, literature which says some says less than 5, less than 6, less than 7. So basically, short total vaginal length. There is a risk factor for that the pessary may not be fitted well. That is one thing. Introital diameter more than 4 finger breadth. If the more finger breadth of this introital diameter, then there are chances of unsuccessful. Atrophic vagina. So whenever you insert in the postmenopausal female, you always ensure that previously you have prepared the vagina, you have told how to apply local estrogen. Okay, then only you insert a pessary for better successful compliance or fitting of the pessary. So deficient perineum. Whenever the perineum is very deficient, when it is very lax, descending perineum syndrome, genital hiatus is very big, large, so usually pessary does not require. Now that are the cases which usually require, because again that cases are very high chances of recurrence of prolapses. So in that, what you can do is you insert a double ring pessary. So you insert 2 pessaries, one larger size up in the posterior fornix as routinely we insert, and the second pessary you insert is just 2 to 3 centimeter inside the introitus, so that you insert. So one is the larger size above, and second is this. So this is double ring pessary in case of deficient perineum. When the perineum is deficient, then you insert the double ring pessary. So these are for the unsuccessful fit. Now what instructions you give to the patients? Once the pessary is inserted, you have to tell some patient instructions. One thing is that pessary is a foreign body, so there will be a reaction to it in vagina. So there will be increase of discharge, will be settled by over a period of time, but you have to inform that after insertion of pessary, there might be increase in vaginal discharge. Otherwise, patient may get fearful. If it falls out, there is nothing to worry. Some signs what you have to say. If the patient pessary falls out, there is nothing to worry. Discharge will increase, nothing to worry. But by after pessary, after going to home, she is having pain. She has to report it immediately. If she has difficulty in voiding, then she has to report. Okay, pain, difficulty in voiding, then she has to report it. falls out, okay, she can come for the routine follow-up whenever she is dated, and discharge also. But if there is foul smelling discharge, then also she has to report immediately. Okay, these are the instructions you give to the patient. Then follow-up. Once you have inserted the pessary, how you ask the patient to follow up? Very first visit, it's said like no longer than 4 to 6 weeks, but you call between 2 weeks the patient. First, whenever you insert the person, within 2 weeks you call the patient. At each visit, what you do is you remove the pessary, you check the pessary for any cracks, its elasticity, you check for the vaginal wall, any pressure, symptoms, ulcer, sores. Okay, after 2 weeks, it will not be in first visit, but for each pessary, for each visit you do, you remove the pessary, you check for the pessary, you check for the condition of the vaginal walls, then you wash the pessary and replace it. Okay, this is you done in each visit. Again, repeat. Whenever in each visit follow up, what are you going to do? You remove the pessary, you check for the pessary for any defect in the pessary, you check for the vaginal wall, any erosion, pressure, ulcers, and you wash it and replace it. And you ask the symptoms of the patient, how relief she is having of the symptoms, and how much there is a development of new symptoms. Might be she might have occult SUIs. When you insert it, might have SUI which was not evident before. After insertion of pessary, now she is having SUI. So that's, so you ask for the old symptoms, you ask for the any development of new symptoms. So this is a follow up. So after the follow-up, complications, everything has a complication to it. So what the complication of pessary? Very only one thing if you have to remember about pessary, I've told in my last video also, pessary is to be inserted only in the patients who are willing to follow up, who are compliant. So comorbid patient who you think will not able to follow up is not an indication or good candidate for pessary insertion. Okay, in that cases you do leave it under local anesthesia. Okay, so follow up compliance is very important. So complication usually of the forgotten pessaries, neglected pessaries, discharge, there are pressure sores, ulcer, vaginal bleeding, erosions are there, and in very chronic neglected for many months or years, it has the fistula. The development of fistula is also seen very rare cases. Again, one thing follow up, first visit is within 2 weeks, as I said. Second visit, you call the patient after 1 or 3 months, and then every 6 months to annually. Depends upon the patient, other factors, her symptoms, how she can come, and other factors you see, other patient condition, comorbidity, what are the symptoms. So first visit is within 2 weeks. Second visit usually call after the 1 month, and then you can call her after 6 and ideally the pessary should be removed every day in the night, wash it and reinsert in the morning. Okay, every day. But obviously, practically patient don't do, or some patient don't like to do. So at least you tell the patient, you teach them patient at least to be done weekly. Remove the removal of the pessary, wash it and then replace it. Okay, so that's why patient compliance, patient motivated patient is very important for a pessary insertion. Patient needs to be educated about the patient, self-care about the pessary. Okay, this is the thing. So how you treat the complication, as we seen in the unsuccessful fitting also, how you treat the complication is, discharge is normal, but if it's obviously foul smelling active infection, then you remove the pessary, you first treat the discharge, then you reinsert the pessary, and after pessary insertion, you ask her to self-care, like daily, and if at least she's not able to daily, then weekly. Still, if she's having discharge, then you can ask her to warm water, clean it with warm water. Okay, she can clean it with some warm water. So usually discharge settles. In foul smelling, if there might be some obstruction or atrophic vagina, then only it leads to foul smelling if it's not properly self-cared for the pessary. So that's why caring of pessary is important. Then what other complication? Bleeding, pressure was, these are all because of not proper size of the pessary, and whatever the complication like a fistula, obviously you have to operate. Sizes, obstruction or pressure sores are there. So it might be the elasticity has been lost, it has not been properly cared, or the size is wrong and it's causing pressure, so you remove it. If it's atrophic vagina, then the complication, chances of complication and severity of complication increase. That's why in inserting pessary in the postmenopausal female, you ask first, you apply first local estrogen hormone supplementation. Okay. Outcomes are very good. Patient compliance is good in a good motivated patient who is willing to. 70 to 92% patient has a good outcome with this pessary. Her symptoms gone. Basically pessary works with the action of like fibrosis. So whenever you insert the pessary in long term, you see the stage 3 has converted initially to stage 2, then 1. So when you see in the follow-up patient, the prolapse actually goes away and patient is much relief of it, and the patient used the pessary for years and years. Okay, so this has been there. So as such, it's very safe and outcomes are good. Clinical tip point: how or which pessary to decide. In short, ring pessaries first. Any patient except for the wall prolapse, we'll see with the uterine prolapse and wall prolapse. So in uterine prolapse, you first insert, give the trial of the ring pessary. These are the silicone ring pessaries which are very few. It ranges from 100 to 250 to 300 rupees. You get this silicone pessary. Depends upon the area where you are and the size. So this is the cheap. So first year in with uterine prolapse, you offer the patient is the silicone ring pessary. Then if its compliance is good, then you add it with support. There are ring pessary with support. You add that pessary, and then if that's better, and if it's not, means if she's having even posterior vaginal uterine prolapse with posterior vaginal wall prolapse, then also you first insert the ring pessary. You can see the compliance. You get the time to see how the patient comes for the follow up, what are her concerns, and if it's better suited pessary gets suited to her, she's okay. Then in that cases, uterine prolapse with posterior vaginal wall prolapse, you can offer her the Gellhorn pessary. So first you choose a ring pessary, then ring pessary with support, and then you shift on to the Gellhorn pessary with the posterior vaginal wall prolapse. Pessary with support are better for uterine, but first because this is cheap, and other pessaries are usually ranges from 5 to 10,000. That's are the ranges with support, without support, knob, Gellhorn, flexible stem, flexible, rigid, short stem, long stem. There are various criteria in the pessaries. Okay, so first you obviously offer the ring pessary. In wall prolapse cases, you offer first your option of choice, but clinically practically is a Gellhorn pessary. Gellhorn pessary. So Gellhorn pessary has a good, then other you can shift over to the donut pessary, and then you can last is the cube pessary, because cube pessary it requires daily removal, and removal is somewhat you have to teach the patient, because it's by creating suction all around. So first you have to remove that suction from the vagina, and then you have to pull it, the cube pessary. Okay, so these are the clinical tips for with uterine prolapse and without uterine prolapse. Hope you found this video useful. Thank you.